Okay, today we're talking about PEEP. We're going to talk about what it is, why we care about it, and sometimes where we might change PEEP depending on the situation. So, PEEP, positive end expiratory pressure. What does that mean? It's a pressure left inside the lung after the breath has gone in and out. There's pressure remaining inside the lung. That's PEEP. Why do we care about it? PEEP is one of the only things that we can control that can improve oxygenation, the other being FiO2, supplemental oxygen. So if we're giving supplemental oxygen, we can change the PEEP and increase our oxygenation. Let's back up a little bit and talk about some basic mechanics of ventilation. Number one, the lung is not one big balloon. It's made up of thousands of tiny balloons. Okay, these are your alveoli, and they come in little sacs like a bushel of grapes. They are fed with deoxygenated blood. They get oxygen. The oxygenated blood comes back here. How that happens is according to pressure, okay? Gases are going to move down their concentration gradients, right? So when I have deoxygenated blood coming through here that's full of CO2, picked up from the rest of the body, it's going to come here. I've got a breath of air in this alveoli. Not a lot of CO2 in here. There shouldn't be any CO2 in the breath we give. CO2 is going to move down its concentration gradient into this and wait to be expelled. The same is true for oxygen. A lot of oxygen coming in, up to 100% oxygen filling this alveoli. There's not a lot of oxygen in this blue blood coming in, so it's going to move down its concentration gradient into the blood and wait to go back up to the heart, shot out to the rest of the body. So if I can increase the amount of pressure that this oxygen has here, I can increase the amount that is going across this membrane and into the blood. Think about, so the second kind of principle that we're going to talk about is what it takes to actually inflate the lung. You're prepping for a party. You're being tasked with inflating a bunch of party balloons. You take a balloon out of the packaging. That first breath to inflate the balloon, to get it from here to here, takes a lot of force, right? You have to break that thing open. The second breath to come from here to there is much easier, and it requires less driving pressure. The same is true of the lung. The lung does not like to be in this state. It likes to be inflated and then deflate back to about half of its normal volume, and it maintains PEEP. Everybody watching this video right now has PEEP. We give ourselves PEEP based on the way we breathe and how our airways are structured. We get about 3 to 5 centimeters. They call that physiologic PEEP. Everyone has it. We are trying to mimic that. So the bottom line is, if we are ventilating someone with a BVM, they get PEEP. Everybody gets 5 centimeters of PEEP. The way we achieve that is with the PEEP valve. And this is set at 5. So it's set kind of like a torque wrench. When 5 is half occluded, that's your setting. That would be 10. All right? So everybody that we ventilate with a BVM gets 5 centimeters of PEEP. Now, what that does is it means that even during expiration, when we're not squeezing the bag, there's still oxygen in here doing its job and trickling into the blood. If I have 0 PEEP and I'm ventilating and I squeeze and I let go and I squeeze and I let go, the blue part is what can push oxygen into the blood, right? I can only get oxygen into the blood if it's here in the alveoli waiting. So if I have 0 PEEP, I only have oxygen here during inspiration. If I select 5 centimeters of PEEP, I now have a baseline of 5. So this entire blue section, I still have inspiration and expiration, but all of this blue section is now available to help with oxygenation. Much more area there, much more oxygen going into the blood. So what does that actually look like? This is your lung, okay? This is your lung on 0 PEEP. I inflate and I deflate. All right, and my fingers collapse. I inflate and I deflate. Okay, that's atelectasis. Now let's add 5 centimeters of PEEP. Inflate. And I still have some left in there. Inflate. And there's still gas exchange happening in these alveoli. All right. So, great. Everybody gets 5. When would we go up? This thing can go up to 20. When would we do that? A couple situations. Number one being the morbidly obese. Now, think about this from a pressure standpoint, okay? The morbidly obese, we're ventilating them. They're most likely supine. I've now got all this mass pushing down onto my chest cavity. I've got an increased pressure in here that's working against me. So I need to combat that with some increased PEEP, okay? So I might go up on my PEEP if we're ventilating a morbidly obese patient who has a lot of mass working against us. Something else that can help, really simple, we talked about positioning as well. If you're ventilating somebody, tilt them up, even just 15 degrees. That can help kind of shift that mass down and off the lungs. A second instance where we might go up on PEEP, pulmonary edema, okay? This could be secondary to congestive heart failure. It could be secondary to drowning. Either way, if you have pulmonary edema, you've got fluid in your alveoli. And the only surface area that's available to exchange gas is what's above water, right? So you've got this green area and this little smidge over here. That's it. I need to make this bigger. I need to expand that surface area so that I can get more oxygen in and more CO2 out. The way we do that is by increasing the PEEP. My alveoli now expand, right, like this, and they stay inflated during expiration. And I've got all this surface area now recruited to help in gas exchange. Now, one last thing. You're ventilating with PEEP. If we're ventilating with the mask and not a tube or a definitive airway, look what happens when we break our mask seal. All right, so we've got PEEP here and we break seal. You lose PEEP immediately. So mask seal becomes incredibly important when we start adding PEEP, because without it, we're not doing anything. So 2-person BVM, anytime we're ventilating someone with a BVM, they get 5 centimeters of PEEP. That is to mimic physiologic PEEP. We can titrate up for conditions such as obesity and pulmonary edema as needed to improve oxygenation. Go forth and deliver PEEP.